Welcome everyone to today's webinar, Non-Invasive Monitoring, Fluid Responsiveness Using the Plus Variability Index and Continuous Hemoglobin. Insights from UCI CMO, Dr. William Wilson. I am Molly Gamble with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be made available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it is now my pleasure to start today's webinar by introducing our terrific presenter. We are thrilled to be joined by Dr. William Wilson, Chief Medical Officer at UCI Health. He is a clinical professor of anesthesiology, medicine, and surgery. With more than 25 years of experience as a cardiac anesthesiologist and intensivist, Dr. Wilson has engaged in research and lectured on dynamic measures of intravascular volume over much of his career. As the CMO for the UCI Health System, Dr. Wilson also oversees patient safety, quality, and experience. He facilitates collaboration between physicians, nurses, and other stakeholders to enhance efficiencies and patient care outcomes. Dr. Wilson, I'll turn the floor over to you to begin today's presentation.
Thank you, Molly, for that kind and really abundantly positive introduction. It's so exciting for me to be able to share non-invasive monitoring in general, but to be able to share non-invasive monitoring in two particularly important areas, which is intravascular volume repletion as well as continuous hemoglobin, is really important, as both of those topics are fundamental now to patient care. I do have a disclosure that I consult with Masimo, a corporation that produces some of the instrumentation and technology discussed in this talk, but I'm non-paid. The collaboration is in the realms of research and thinking about future systems. So this first portion of this talk revolves around the non-invasive monitoring of fluid using the Plus Variability Index, the PVI. And fluid optimization is something that is critical to care of patients, particularly those that are in the intensive care unit or in the operating room or in the emergency department, places where the dynamics of fluid are changing rapidly. And as depicted in the image, the goal is to optimize fluid. Patients that are critically ill, multiple trauma, or those in the operating room with large blood loss, the risk there is hypovolemia and inadequate tissue perfusion. Whereas in patients where we may have given too much fluid, we have this other image that is familiar with us. Essentially, with too much fluid, particularly when it is not blood or whole blood, when it's crystalloid, we get into problems of interstitial and tissue edema. And the poor perfusion in certain organs, and for the lungs, interstitial edema decreasing our ability to oxygenate patients can be problematic. So it's how do we get that sweet spot? And one important element is having an evaluation of fluid responsiveness. On this Frank-Starling curve, there are two hearts depicted on the stroke volume versus preload curve, the so-called Starling curve. The heart on the bottom right, when a bolus of fluid is administered, there's an increase in stroke volume. Whereas in contrast, the heart at the top of the curve, we can give a preload bolus, and there is no further increase in stroke volume. A patient and their heart that is on the bottom left part of the Frank-Starling curve is considered to be volume responsive. Patient who is at the top of the curve is considered non-responsive. And there's different ways that we can determine their fluid responsiveness. One is to give a bolus of fluid. That could also be accomplished in a patient in the intensive care unit by raising their legs. It's not so easy to do in the operating room. Another way to determine the fluid responsiveness is by looking at the arterial pressure variation that occurs with positive pressure ventilation. And on the Frank-Starling curve on this image, you can see that the patient on the bottom left is volume responsive. There's a lot of systolic pressure variation of the arterial pressure waveform depicted in the image on the right, whereas the patient at the top of the Frank-Starling curve, there's very little variation in their arterial pressure waveform. And in order to achieve this type of a curve and analysis, one has to have a patient that is intubated, receiving positive pressure ventilation in the 8 mLs per kilo or more range. And that patient also should have a normal sinus rhythm. And the chest should be closed. That is, if you have a cardiac patient, the chest is open, you won't see quite as much systolic pressure variation with a positive pressure breath. So in the normal circumstances that are in a normal patient with a sinus rhythm, you'll see a waveform that would either reflect that they're volume responsive or not. Now, in the prior Frank-Starling graph, we showed that if a patient gets a fluid bolus, the heart on the bottom right increases with stroke volume, whereas the one at the top does not. If we look at this image on the right side of this graph here, how is it that an arterial pressure waveform in a patient receiving positive pressure ventilation would reflect that same data? And the reason is that there are preload and afterload changes to the right and left sides of the heart that occur with a positive pressure breath. The first change that occurs with a positive pressure breath is you'll get an increase in stroke volume of blood at the left ventricle as the pulmonary veins squeeze blood into the left atrium and then left ventricle. So there's a little bit of an increase. And then after that, with a positive pressure breath, you'll see a delta down component, which is related to the decreased venous return to the thoracic cavity and the increased afterload of the right ventricle with a positive pressure breath. And then when that breath is relieved, then you'll go back to reversing those changes. So essentially what you get with each positive pressure breath is a little fluid bolus. And with positive pressure breath, it'll go up and then down. And the drier the patient's intravascular volume status is, the more of a responder that the patient will be. Whereas the part on the bottom left is increasing with each bolus. The heart at the top is not. With a patient who is being mechanically ventilated at 8 mLs per kilo and is relatively intravascularly depleted, you'll see much more of a change with stroke volume than the patient who has intravascular repletion. And so that'll be the difference that you see. And we've known about this for quite some time. Osrel Perel actually started studying this initially in dogs and then in humans several decades ago. And then others have followed, Machard and others. And what we began to recognize is that some measures of fluid responsiveness, such as stroke volume variation, positive pressure variation, can be used to, looks like the slides, let me just bring these slides back into order here. There we go. One thing that we've recognized is that those measures which are static, such as a CVP measurement or a global end-diastolic volume, they don't correlate very well with the patient's intravascular volume status. Whereas in contrast, those dynamic measures such as stroke volume variation and positive pressure variation have a very good correlation, as evidenced in the receiver operating curves shown in this picture. In this table demonstrated on this slide, provided out of a review article by Paul Merrick, you can see summarized the various parameters that are good measures of intravascular volume responsiveness, such as stroke volume variation, post pressure variation, compared to, again, static measures like CVP, even pulmonary occlusion pressure. But it turns out that not only can you obtain data like stroke volume variation that would come from an indwelling arterial cannula, we can now obtain this data non-invasively just simply by having a patient connected to a pulse oximeter that has this capability. And that's by measuring the plethysmographic waveform with pulse oximeter. In fact, the Masimo system that's been able to provide this data for really more than a decade now was FDA approved in August of this year. So let's look at how there's a correlation between the arterial pressure waveform depicted on the image in the middle left side of this slide compared to the arterial plethysmographic waveform that will come with pulse oximetry. We've already gone through the physiology of why there's a delta up and a delta down with a positive pressure breath. Again, as a reminder, with a patient who's intubated, mechanically ventilated at 8 mLs per kilo or more and is in a sinus rhythm with a closed chest, with a positive pressure breath, you get a brief delta up, which is related to blood being squeezed out of the pulmonary veins in the left atrium, left ventricle. And then as that positive pressure breath stays longer, you will start seeing the negative aspects of a positive pressure breath, that is, decreased venous return to the thoracic cavity, so decreased preload to the right atrium ventricle, and the increased afterload of the right ventricle, not letting the blood get over to the left side of the heart. And when that is released, then it goes back. Well, the same type of phenomena occurs with the pulse oximeter waveform, as shown on the right. And when we're looking at an arterial pressure waveform, we're looking at either the elevation of the systolic pressure compared to an inhalation versus an exhalation, or we can look at the pulse pressure as shown in this. Whereas when we're looking at the plethysmographic waveform, we are looking at what's called the PI max and the PI min. And in the next slide, we're going to talk a little bit about how you get to that. So the PVI index is a dynamic index that ranges between 0 and 100. It's obtained non-invasively. You do not need to have an A-line in the patient to obtain this. It comes right off your pulse oximeter. And the PVI indicates the variability of the pulse oximetry waveform, which correlates with the arterial pressure waveform that would occur with an invasive cannula. The graph and image on the right-hand side shows, once again, the plethysmographic trace, and the equation that's used to obtain the PVI is pulsatility index max minus pulsatility index min divided by pulsatility index max times 100. That gives you the PVI. Well, the question is, what's the pulsatility index? And if you look at the image on the left side of the slide, that shows you how the pulsatility index is derived. It's essentially the alternating components divided by the constant component. So the AC represents the variable absorption of infrared light secondary to arterial pulsations, whereas the DC component represents the constant absorption of infrared light due to skin and other tissues. and that AC divided by DC times 100 is the PI. And moving back to the right-hand side of the slide for the equation for PVI, it's the PI max minus the PI min divided by the PI max times 100. And that number is displayed on the pulse oximeter, and you can get a graphical representation of how the patient's intravascular volume is responding to a positive pressure breath by looking at the plethysmographic waveform of the pulse oximeter trace as well. So the great news is that because of this correlation, the PVI can be used as a measure of fluid responsive without placing an A-line. And providing the patient is connected to pulse oximeters that have this capability, such as the Massimo Rainbow that has, rather than just a oxy and deoxy hemoglobin measurement with 2 LED waveforms, they use actually 7 waveforms of light are evaluated. And with this providing, the patient has a low plethysmographic waveform, less than 13%, then that would be a non-responding, whereas if it's more than 13%, that patient would be classified as a fluid responder needing some additional fluid. So this allows a PVI to be used as a non-invasive dynamic indicator of fluid responsiveness. Once again, that's providing the patient is being intubated, mechanically ventilated at 8 mLs per kilo or more with a normal ITE ratio, minimum PEEP, is in a sinus rhythm, and has a closed thoracic cavity, as a patient in the ICU typically would. So looking at some data, Forgot et al. Published in Anesthesia and Analgesia studied 82 patients undergoing major abdominal surgery, and she noted that the PVI-based goal-directed fluid management had a significant reduction in the lactate that the intervention group had compared to the control group, and also there was a decrease in the amount of fluid that was required intraoperatively for the patients that were receiving the goal-directed therapy. And there was a difference between the intervention plethysmographic variability index group compared to control, not just intraoperatively, but at 24 hours and 48 hours after as well. Another investigator, Thiel et al., published in Journal of the American College of Surgeons 2015, studied 109 patients undergoing colorectal surgery using a ERAS, Enhanced Recovery After Surgery protocol. And these researchers found that implementation of the ERAS protocol, which include use of PVI index, led to improved reductions in length of stay, complications, and cost for patients, as well as an improvement in patient satisfaction. The length of stay and the median 30-day costs are showed here for the patients that were undergoing the continuous PVI indicator of patients' intravascular volume responsiveness, had a length of stay of 6.8 days compared to the non-protocol, rather, had 6.8 days compared to the protocol patients at 4.6 days. And there was a cost saving of almost $7,000 for the patients that were receiving the PVI monitoring as part of the ERAS protocol. So let's now look at continuous hemoglobin monitoring. And here is a graph of hemoglobin versus time for a patient in the operating room undergoing a long procedure, and there was some blood loss, and there were serial hemoglobin measurements. Every one of these hemoglobin measurements takes some time. You have to acquire the blood and then send it to the lab, so there's a turnaround time. And then you compare that to if the patient also has a continuous hemoglobin monitor on, and look at how close the correlation is between the continuous hemoglobin monitoring and those serial hemoglobin measurements. Well, it turns out that with new technology, and I already mentioned 7 waveforms of light, that you not only can get oxy and deoxyhemoglobin, but you can also get methemoglobin, carboxyhemoglobin, essentially all the species of hemoglobin that you would get in a co-oximeter, and you can get the continuous hemoglobin measurement in these patients, as well as a measure of the PVI, the Pulse Variability Index. Well, so it's great to know that we have this capability. Another factor to consider is that red blood cell transfusions are not always appropriately given. And some of the reasons why that patients will receive an inappropriate transfusion is that there was some haste, or maybe the physician was working without all the data that would be helpful, i.e., it was in the operating room, there was some bleeding going on, but did not really know exactly what the hemoglobin was at that time, knew what it was before, and knew what it was after, but exactly what is the hemoglobin in between these lab samples, it's really important to know. And if you know that, you can decrease the amount of unnecessary blood. In this top study by Ari Shander, they looked at 494 studies, 450 clinical scenarios, and found that really using their scrutiny, only about 12% were appropriate for looking at what the hemoglobin was and the patient's condition. In addition, transfusions may be associated with additional morbidity and mortality, problems such as trolley, blood mismatch. Paul Merrick and others published in Critical Care that there's a significant increase in not just mortality and morbidity, but also infections in those patients that receive blood transfusion compared to those that don't. Further, there is a financial cost. And in this other study by Shander, published in Transfusion 2010, they looked at 4 different hospitals, 2 in the United States and 2 in Europe. The American hospitals were in Rhode Island and in New Jersey, where Shander was practicing at that time. And the 2 European hospitals, one in Switzerland and one in Austria. And they noted that the cost per blood was fairly similar, but there was also an additional cost of getting the blood processed, type and cross, storing the blood, acquiring the blood. If you had your own blood bank, then you didn't have to pay for the blood, but there was the cost of acquiring it. If you didn't have your own blood bank, then you would have to also pay for that. And so, although there were some differences, there were significant costs. But the biggest cost to a patient who receives a blood transfusion when it's not indicated is that they may have a complication and with no benefit. And so we need to avoid that. So here are now 6 different studies that have been conducted in the United States as well as around the world that have demonstrated an benefit of continuous hemoglobin monitoring. This has been shown for orthopedic surgery, neurosurgery, abdominal surgery, hip trauma, spine and cytoreductive surgery, as well as post-surgical cancer patients. We'll go through a couple of these. The first one by Ehrenfeld, Jesse Ehrenfeld et al. Was performed at Mass General. This was a randomized trial of 327 patients. And by using the continuous hemoglobin monitoring, they were able to have a marked reduction in the rate of transfusions compared to the group that was treated with standard, i.e. no continuous hemoglobin monitoring. Those patients would need to have blood sent to the lab. It was an 87% reduction with a p-value of 0.03. In this study by Awada, published in the Journal of Clinical Monitoring and Computing, 2015, a prospective cohort of 106 neurosurgical patients. It was found that those that were using the continuous hemoglobin monitoring had a reduction of almost 1 full unit, 0.9 units, compared to the cohort that was treated with standard of care, and this was significant to a p-value of 0.001. Similarly, the continuous hemoglobin monitoring, when used in conjunction with the PLES variability index, can be very powerful in terms of avoiding transfusion when the hemoglobin drops. It might be just to dilution alone. And in this presentation by Azrael Perel, in this image, it demonstrates that the patient was undergoing liver surgery, which you can have lots of blood loss, and the patient's PVI had been increasing, but after the patient received a 2.5 liter crystalloid bolus, the PLES variability index markedly decreased towards normal, and the patient's hemoglobin dropped, but because the patient was otherwise stable with a normal PLES variability index, they were able to avoid transfusing. Now, here's a study that was recently published in the Journal of Clinical Monitoring and Computing by Cross, and the study was conducted in Limoges, France, and included 18,716 surgical patients. Some were cardiac, some were non-cardiac. And these patients, and if you look at the black box first before looking at the algorithm, I'll go through the algorithm in a moment. If you look at the black box first, there were 3 groups. Group 1 was a almost year-long period in 2013 where 9,000 plus patients were managed without continuous hemoglobin or PLES variability index monitoring. Group 2 was conducted in 2014, 5,800 plus patients that received just routine care, no PLES variability index, and no continuous hemoglobin monitoring. And that was compared with a simultaneous time period in 2014 where 3,575 patients did receive the goal-directed therapy that I'll go through in a moment, using both continuous hemoglobin monitoring and the PLES variability index. So let's look at the algorithm that was used on the right-hand side of the slide. The patients all received a basal fluid load of 2 mLs per kilo per hour. And then the PLES variability index was evaluated as the patients were all being mechanically ventilated at 8 or more mLs per kilo. These patients were in the sinus rhythm of closed chest. And if the PLES variability index was less than 9, no fluid was administered, whereas if it was greater than 15, they would get a fluid bolus as a fluid load. If it was in the 9 to 15 range in the middle, then they would do an evaluation, a test with a small bolus of 100 to 250 milliliters of crystalloid. If the patient did not show any decrease in the PVI from the 9 to 15 range, then no fluid was given at that time. It would be rechecked later. But if there was a decrease in the PVI, then the patient would receive a full fluid load. And the fluid load would depend on whether the hemoglobin was greater than 7, where they would just receive crystalloid or colloid, or if it was less than or equal to 7, then the patient would receive 1 unit of packed cells. Using that algorithm, the following data was acquired. As you can see on the survival curve, the patient that were receiving the goal-directed therapy, which was a combination of continuous hemoglobin monitoring and the PLES variability index as described in earlier slides, had a significant survival improvement compared to those that were the historical controls from 2013, as well as the concomitant cohort in 2014 that were treated with standard of care. They also elected some patients after this when they had no longer had in the operating room the continuous hemoglobin and the PVI measuring ability, and they reverted back to the data from 2013 and was similar to the data they had in 2014 without that. It was overall what they found was that there was a 33% reduction in 30-day mortality and a 20-day reduction and 90-day mortality in the patients that received the goal-directed therapy using both continuous hemoglobin monitoring and the pleth variability index, both obtained non-invasively off the pulse oximeter. They also found that there were fewer units of blood transfused, though they had earlier transfusion in general, but less overall, or earlier if was indicated. And there was also a decrease in complications that was significant. In addition, there was an improvement in satisfaction. So overall, taking the data on continuous hemoglobin monitoring and continuous plethysmographic variability index monitoring, we have 4 major takeaway points. The first is that dynamic measures of volume responsiveness, whether it's with stroke volume variation or pulse pressure variation, as you would get with an indwelling arterial cannula and sometimes more advanced devices, that is an optimal way of evaluating intravascular volume administration. But we can also do it with PVI, and this is the best way to guide fluid management. Number 2, that because the PVI has the advantage of being non-invasive and is widely available just on your pulse oximeter, this is a benefit. Third, continuous hemoglobin monitoring provides real-time values without the delays that would be related to sample acquisition and the full turnaround time of blood going to the lab. And even if you had a HemoQ or a on-site point-of-care testing, it does take time and attention when the provider may be busy doing other meaningful work to obtain those samples as well. So the turnaround time would be less than going to the lab. Finally, an integrated goal-directed therapy approach using both the pleth variability index, the PVI, as well as continuous hemoglobin monitoring can result in fewer units of blood transfused and improved outcomes, including survival and patient satisfaction. So now I would like to thank you for your attention and be happy to entertain any questions.
Terrific. Thank you, Dr. Wilson, for that fantastic presentation. A couple questions have come in here, so let's start with this one. An attendee would like to know, do you need an A-line?
No, you do not need an A-line. So thank you for that question. Prior to having this ability to, with a pulse oximeter, have the PVI, the plethysmographic or the pleth variability index, recorded and reported continuously, and you can see the waveform. Prior to that, yes, you would have had to have an A-line in patients to either look at stroke volume variation or pulse pressure variation. It is possible with lots of construct to obtain some of this data with a oscillometric blood pressure measurement, but it is very cumbersome, not easy to do, and the fidelity of the data is impaired. So that's essentially point number 1 and 2, that we have the most robust way of evaluating intravascular volume is using one of these measures, but the PVI has the advantage of being non-invasive, no A-line necessary. Next question.
Okay, thanks, Dr. Wilson, and thanks, attendee, for that question. And just a reminder for those with us today, you can submit any questions you have for Dr. Wilson by typing them into the Q&A box you see on your dashboard. So, Dr. Wilson, the next question that came in is, do you envision a role for PVI monitoring to determine if blood transfusion is indicated in a non-surgical but anemic stable patient? Can this replace HGB level alone as an indicator for transfusion?
So typically what one would like is a correlation with a hemoglobin sample as well as continuous hemoglobin monitoring, so you can make sure that your system is calibrated and functioning. Just about every publication that has come out is showing that the continuous hemoglobin monitor is within 1 gram per deciliter of the actual laboratory data, but it's always good to have at least one sample from the lab, and then every day or two, depending on how things are going, to recalibrate and make sure that the data that you're getting is accurate. So in general, yes,
Perfect.
you can do most of the management without, and you just don't need serial hemoglobin measurements. That's the key.
Okay, thank you for clarifying that, Dr. Wilson. This next question is from an attendee. Have you seen problems with plasmographic waveforms in hypotensive patients?
So yes, every model and every system has some confounding factors. We've mentioned a couple already. If the patient is having many cardiac dysrhythmias, then both the systolic pressure variation and the plasmographic waveform will not be as robust. Similarly, if the patient is being mechanically ventilated with very small tidal volumes, you won't get as much of a challenge to the system to get a good Starling curve going up and down. Further, if the tidal volumes are so big, you might have excessive variation. Another problem could be a morbidly obese patient that has such a confined thoracic cavity that massive amounts of pressure are applied to the inside of the thoracic cavity, doesn't move very much, so you get exacerbation of both systolic pressure variation you get with an A-line as well as a plasmographic trace. Patients that have COPD, it can be more problematic. But if you have a normal body habitus, you're intubated, mechanically ventilated at 8 mLs or 8 to 10 mLs per kilo, patient in sinus rhythm, the chest is closed, most of the data from a plasmographic trace will correlate very well with a arterial pressure waveform.
Okay. Thank you, Dr. Wilson. Attendee, thank you for your questions. They're rolling in. So this next one is, can this be used to guide fluid therapy in sepsis patients?
It can, absolutely. Now, we have to also recognize that for every patient that we manage, we're always looking at preload, afterload, contractility, whether in the sinus rhythm or not. And so what we're talking about with the plasmographic waveform variation, the PVI, it is a measure of the intravascular volume repletion, so it's a measure of your preload. But if you also have afterload problems, as would occur in a septic patient, that is, the afterload is low, they have a low SVR, then although they may also be dry, the problem may not be that the problem may not just be that they're dry. It may be that you have to add a little bit of norepi or some other vasopressor in order to elevate the pressure. So yes, it can be used, and yes, it should be used, but you cannot use it alone. You have to take other factors into consideration.
Okay. Thank you for the guidance. Another question, can PVI be used on non-ventilated patients?
It can be, but it's fraught with problems. That is, the data that I quoted is only going to be robust in a patient that is intubated, mechanically ventilated, and you're using 8 to 10 mLs per kilo with minimal PEEP, normal IDE ratios. There will be a PLES variability index in non-intubated patients, and if they're super dry, you'll see a lot of change there. Just like the arterial pressure waveform will show a lot of systolic pressure variation in very dry patients that are not intubated, but it's just not as robust. And with the PVI, typically we use as a break point about 13% or more, and with an indwelling arterial pressure cannula, we'll typically use somewhere of like a 10 to 15 millimeter mercury difference in the systolic pressure variation as one endpoint. Next question.
Okay. Can this system be utilized in the non-intubated patient as in a massive maternal hemorrhage, for instance?
So let's take that question apart. So the non-intubated patient, what I just said still applies. And maternal hemorrhage is one category of a massively bleeding patient who is prone to becoming intravascularly depleted. And one excellent measure of the volume repletion is if you had an A-line in systolic pressure variation. If you don't, the plethysmographic index, the PVI. But in terms of how much you can count just on that one measure, it's best that the patient's trachea be intubated and that they be mechanically ventilated so that you can have a number to hang your hat on, number in the 13 range for PVI.
Okay, thanks for breaking that down. Let's see here. Can the dilution effect on hemoglobin when fluid is given be captured by the labs?
Yes, but the problem that we're avoiding by having the continuous hemoglobin measurement is real time. If you're just having samples, say every 30 minutes or every hour, every 2 hours, then what's happening in between those samples is not being detected. And so after a patient receives, let's say, a 1 liter bolus of crystalloid, within 5 minutes or so, that 1 liter is distributed throughout the entire system, and whatever your hemoglobin is at that time will be accurate. If there's massive bleeding going on, you may be bleeding so fast that the hemoglobin doesn't have a chance to drop as much as the blood if you're not repleting patients. So all these factors, of course, need to be taken into consideration in massively bleeding patients.
Okay, and this will be our final question for the webinar today, and that is, does UCI use any particular threshold or protocol for using PVI? Is it similar to SVV?
Similar to stroke volume variation. With stroke volume variation, we typically use more than 10 millimeters of mercury. With PVI, more than 13% of the PVI. We also have some closed loop systems that we use as part of our data collection and for ongoing research. Maxine Cannison used to be here. He's now at UCLA, but he started a lot of that research that other members of our team are continuing to work with, and we find that a dynamic measure of intravascular volume responsiveness is really critical to intravascular volume estimation, and when it can be done with pulse oximetry non-invasively for the patients who would not otherwise need an arterial line, then that's a great bonus.
Okay, well, thank you, Dr. Wilson. So that is all the time we have for today. Dr. Wilson, I want to thank you for your excellent presentation, and also I want to thank, excuse me, Massimo for sponsoring today's webinar. On behalf of Becker's Healthcare attendees, we hope you enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you very much.
Thank you very much, Molly. Happy to help.